And we have also different surgeons tried surgery to remove the apex, and it didn't work. And now we decided to remove the tooth, to remove the cyst. And the difference with the former case is that here we have bone, so we can do it immediately. Okay? Exactly as you saw it, the same case, socket shield, implant, filling bone, membrane, and suture, and it's how it looks like. Here we needed a connective tissue graft because of the barrier type. And that's how it looks like. In this area, I won't have a lot of scar tissue. It's not like in the keratinized gingiva. That's how it looks like. And that's 2 months later, where a pretty good result. And 4 months later, we can see through the gingiva a nail, a pin. Probably in 1, 2, or 3 years, we will make a little incision, a very little, and remove just like that the pin, and make just a little part of cyanoacrylate or a little suture point, and it will be, the problem will be solved. But look at the quality of the results. It's just a temporary crown. I think the ceramic is going to be done, or it's recently been done. But look at the results after 4 months with this protocol, and try to imagine if we had done a delayed approach, what kind of result we would have. That's what I want to share with you. Anticipation, immediate placement, immediate aesthetics gives, for me, in my experience, the best results. And with the X3 implants, it allows me to do that. Let's see this case. It's a female, 64 years old, and I know already put implants several years later, and she got a fracture of the lateral teeth. That's how it looks like, and that's what we did just former, the postures. And on the planification, she comes from, she has a long way to do. I asked the prosthodontist to remove just the part of the root which is fractured, to give us temporization and to avoid to have too big infection. So we removed, you can see this part of the root, and then we could make the planification to make, it was for me classical, so remove the tooth. We have lost a part of bone, remove the teeth, immediate placement, augment the bone with a laminate from the ramus. Now it's a very classical protocol for me. And I did this surgery as a live surgery. I had 15 dentists in my training center. And we'll see the surgery, what happened to me. The planification, a template. Okay, let's start the surgery. As I showed you, we removed the teeth, the groove, we had infection, okay, Okay, then drilling and putting the implant. Classical now. I put my implant and I wanted to have the good axis. I played. And then you can see that because of the trajectory of the bone, it was a little too buccal and I wanted to change the axis. And then I switched and all the buccal bone broke with the implants. No bone, no buccal bone. It was a live surgery. I had to show an immediate placement and it happened. It's the real life that can happen. So I needed to elevate the flag. I had no choice. We changed the protocol. I put the implant. I put the implant into good position. And to be sure, because when you have lost the bone, when you introduce it, sometimes the implant wants to go a little in the buccal position. So I put it, and with my osteotome, convex, this one, and hammer, I tapped on the implant to put in the palatal plate, okay, to get the primary stability. Of course, it's not excellent for the surface treatment, but just it's better than nothing. And then I had to build again this one, and we decided that's how it looks like. Now, two options. The classical option is I put a membrane, I make a GBR, I cover, delayed approach. That's the easiest way to do it. But it was not the deal with the dentist. They wanted to see an immediate placement. They said, okay. And they were so happy to see me with such difficulties that they love to see that. Because how will do manage this problem? And we harvested a piece of the ramus. Okay? And that's how, when we split, how I showed you. And then I split it in 3 parts, in 3 laminates. And I had no choice at this moment to use, of course, osteosynthesis screws. So we had to fix the 3 blocks. And with this augmentation, I increased my primary stability because I have 6 screws to fix the blocks. So now the implant is, it's okay for the immediate aesthetic.
Sorry, doctor, let us help you to fix the uniformity first.
You change it?
Yeah, we will check it immediately here. Just for some minutes.
Is it okay? So that's how it looks like. Then impression and doing. That's how it looks like on the X-ray. Temporary cone. I preserve the papillas. I preserve the gingiva. That's essential for me. That's the main point, the key point. I have what I wanted. It was a little longer than what I thought in the beginning, but that's 20 days post-operative, and after 2 months, that's a part of the cylinder, we have a very, very nice result with the gum. And she will start now the ceramic. But this case is to show you that even in extreme cases like that, when you are able to make immediate aesthetic, you get the best results. The limit is, of course, the patient must have the tooth. If the tooth is already removed, you don't need to do that. You make a classical approach, of course. But when you have the tooth, my goal is to make the maximum to be able to maintain what the nature gives to me, as this environment, this gingiva natural emergent profile. Just to use it because the natural has drawn it for me and I want to use it. Sometimes it's not possible, but as far as I can to do immediate aesthetic, I do that. And that's the proof. And it was in life, and I had no choice, and I had to improvise. And I had no choice because I had a lot of people who were looking to me, at me, sorry.